Good afternoon, everyone. Thank you for coming. Shalom aleichem, basim qatiyetun. This is the second time that we have this convention in this about mental health. The necessity that Assyrian American Federation saw in our community all over this country, if not the whole world, that is dealing with mental health, made them to have this, ask the people in the field to have this talks to destigmatize, deconstruct the stigma, and to talk more about mental health, and people be more open about talking mental health. Those who have been in the convention in Florida last year, which was the first time that we talked about, we brought up the issue of depression, and we talked about depression. This year we thought that it's better to address anxiety, as it has been mentioned by many in our community at any age that they are dealing with this problem. So this talk today that you see, myself, I'm Dennis Gelyana. I'm a psychiatrist practicing in Illinois, and with me here is Dr. Juliet Dinkha, that also she's from Chicago. Also, she works from American University in Kuwait, and she's a licensed clinical psychologist. Dr. Ninos Adams is with us as a psychiatrist in California. And here I want to mention that just knowing Dr. Ninos Adams, we all should be proud as Assyrians as having him in our community, and he can be an inspiration for generations. Dr. Ninos Adams, when he was at the end of his medical school, toward end of his medical school, he was diagnosed with an illness, retinitis pigmentosa. So those of you who are familiar with this illness, this is an illness that actually we cannot do much about it. It's a progressive, and many times we don't know why it happens, but the person loses his eyesight. So he, during the residency in psychiatry, he did it as his eyesight was diminishing, and since 3-4 years ago, he has been legally blind. But he has been very active in the community, and he has been very active in his field for all kind of people, and very helpful for people with dealing with addiction or other kinds of mental illness. So here today also he will talk with us about anxiety. So just knowing him is good to know about him and be proud of him, and hopefully many people will learn from him. Also with us is Christina. Christina is activist from Michigan. She founded and worked with Assyrian, Chaldean, Syriac mental health, and works among the nations with surveys, and they work very hard in their organization to, again, the same goal of destigmatize and helping people with mental health in our community. Two people that are not here with us, but we'll mention their name, Linda and Rania. Both are school social worker and licensed clinical social workers in Chicago. Both have years of experience in school, private practice, residential areas, and they gave us some words of wisdom that we'll share them later during the panel. So when we talk about anxiety, what do we mean by anxiety? Anxiety is a sense, is a feeling. It's related to let's call it system in the brain that we call it alarming. So what does it mean? Most of us, when we get too close to a danger, we know what to do. Something stops us. So that comes from, is autonomic, comes from the many factors in the body and in nervous system, and it is the sense that at that time give us is a sense of restlessness, a sense of uneasiness, not pleasant. Many of us, we need it, and all of us actually, we need it. And we think that anxiety has been a part of like survival for human beings, those who were not afraid of risk-taking behaviors, not afraid of snakes or others, maybe they didn't survive. So it helps to the level for all of us to survive. If we don't have anxiety about an exam, maybe we will not study about it. If we don't have anxiety about our daily living, maybe we will not work. So part of it is necessary. But when is the problem? Okay, the problem is when this goes out of control. So when it goes out of control and fires all over and over, so then interferes with our daily functioning, with our thinking, with our planning. So, and some people, they have it, and again, we don't know why. There are some theories. The difference between anxiety and fear. In general, fear is about a known object. I see a lion, so I'm afraid getting close to it in a zoo. I see something that's like a snake or something, I don't get close to it. But if it's or a cliff, I be very careful. So we know what we are afraid of. But if anxiety usually is unknown. We just worry something bad may happen. For example, a person, as we said, wants to get on cannot be in an elevator. What will happen in an elevator, I don't know. I cannot be in an elevator. But what if that person lives in Chicago and needs to go for citizenship test, needs to go for, like in a federal building, in a high-rise to take the test and later on to take the oath. So if he cannot get in that elevator, none of those will happen. So that's where this becomes a problem. Or like some people, again, they're afraid that what if I leave the house, something bad may happen, so they never leave the house. So these are things that we see in anxiety. We talked about that we really don't know where it is, but we know something about it by studies. Unfortunately, just like many other parts in mental health, we don't have people to go and have a blood test and an imaging and we say, okay, this is the diagnosis. It's mostly by definition, by criteria. But whatever researchers have shown, there are several networks in the brain and parts in the brain that are involved in this anxiety. The most part that has been studied a lot is in the size of almond, and it's on each part, and the name that we call it is almond in Greek, amygdala. So this is on each side of the brain, and especially on the left side is known that it's work more with anxiety. Also, when we talk about anxiety and about brain, we're talking about neurochemicals, neurochemistry that we have. So as you see, there are neurochemicals that so far we know as neurotransmitters that helps how the neurons communicate with each other, serotonin, norepinephrine, dopamine. So, and we know that the amygdala that we said usually works with serotonin. So we know that, for example, when there is anxiety, there is a problem with serotonin. But it's not that simple, and there are other factors involved too. Okay, again, just like any other illness in any other part of the body, mental health illnesses also are biopsychosocial. So it's not only the biological part, there are psychological part and social part that affects that illness. So when we talk about anxiety disorder, that we open it more in during the panel, first we should make sure that there are so many things that we call them secondary causes that can cause a general health medical condition, a medication, a substance have been abused, or other things. They can all show themselves with symptoms of anxiety. So first thing, when we ruled all of those, then we have with something that we know that this is anxiety, but we don't know where it comes. We cannot find a secondary cause for it. So then the term that we use it in psychiatry is that this is a primary anxiety. And primary anxieties, as they are in DSM, so far DSM-5-TR, which is the last edition of the DSM, it means that people in the field, when they look at the researchers' data every, let's call it 10 years, they look at this and they change the criteria and the classifications of the diseases. So for anxiety, whatever today we have, these are illnesses that are considered as primary anxiety disorders. Separation anxiety, specific phobia, social anxiety, which is very common, panic disorder, agoraphobia, and generalized anxiety disorder. And why we should treat this anxiety, why this is important to address them in ourselves, in our family members, in our children, or people that we know, because we know that there are consequences. One of the main consequences that you have all heard, and unfortunately we hear a lot in our youth population in this country, is self-medication. And when they do self-medication, unfortunately they go with drugs that are very expensive, we can say, in their life. It takes their life. We have served so many people in our community, so many young people, they lost their lives by overdose. And when we see many times, maybe they had underlying anxiety that they were just looking for somehow to get rid of it. And alcohol is the main common. I always say that alcohol is one of the best anxiolytics that we have, but also is one of the main potent depressants that we have. So people that they use alcohol to get over their anxiety, they can get depressed, and usually when they are under that influence, that's the time that they take their life. And as we said, anxiety without treatment goes and ends with depression. Okay, so these are things that we want to discuss with our panel. So first, Dr. Ninos, I want to get back to you and ask you the first question. A person comes to your office and tells you he suffers or she suffers from anxiety. How will you approach and how will you evaluate that person?
Good question, thank you. So the first thing I do is I ask a bunch of questions to break down, is this anxiety the diagnosis, or is this anxiety a symptom of another diagnosis? Because besides the diagnoses that Dr. Gelyana just mentioned, there are many other diagnoses that we have that anxiety is a part of them. So it's important to kind of peel the onion and find what's going on. So my basic evaluation starts with a medical history, because, for example, asthma is one example that I give to people, that the medication that you take for it can sometimes cause you to have anxiety. Or if you take a steroid, for instance. So I get a medical history. I get a substance history. So like Dr. Gelyana mentioned, again, alcohol, tobacco, drug use. A lot of these drugs and substances in intoxication can cause anxiety, but mostly in withdrawal can cause heavy-duty anxiety. So it could be that there's something going on over there. Next, I get a social history. Are they married, single, divorced? Do they have kids? Kids are a great source of anxiety. Sometimes spouses are a source of anxiety, hopefully not. But these things can happen too. So then you have to find out what's their education level, so you know where to meet them when you're speaking to them, what kind of words to use, what kind of a job do they have, do they have religion? If I'm not pushing any religion on my patients, But it is statistically shown that people who have a religion have less anxiety. Do they have legal issues? Are they constantly running from the law? You know, I would be scared too if the police were constantly after me, for instance. Then I dive into their psychiatric history. Have they had hospitalizations? Have they had suicide attempts? Do they hurt themselves? A lot of people caught, burned, scratched. That's a big thing. Have they been a victim of abuse? Is this part of an abuse history? Post-traumatic stress, flashbacks, nightmares, anxiety, hypervigilance. And again, I like to see what medications they've taken in the past to see if they don't know that they were being treated for anxiety. If they tell me the name of a medication that a regular doctor or a primary care doctor, who are the main people who treat the anxiety more than us psychiatrists, have given them medications for in the past, and maybe they've been dealing with something for 10, 15, 20 years. So those are my basic questions I go through, and then I ask them about their symptoms. When did they start? How long have they been going? Are there any alleviating, aggravating factors? Is it caused by something? Is it identifiable? And then we sort of say peel the onion from there to find out what's going on underneath.
Okay, very good. So now let's imagine that you did all the blood work that you needed, all the tests, all the history, and everything is clear. So then what?
Then I break it down to treatment. So my treatment goes in 3 steps in order: lifestyle modification, therapy, and medications, in that order. So lifestyle modifications, I find out what are they doing in their life. Do they have good sleep hygiene? Do they wake up the same time every day? Are they sleeping erratically? Do they do physical activity? Are they physically fit? Are they going places where they're constantly in danger? These kind of things. So I do some lifestyle modifications. Then I recommend therapy. I myself do some brief therapy with the patients before I send them to the therapist. I practice stoicism. Essentially, very simply put, you take everything in your life and you categorize it into 2 groups: things you can control and things you cannot control. If you can't control it, let it go. If you can control it, make an action plan and attack that action plan and work on these things that you can control. It's very easily said, not very easily done, but with practice, everything in your life can be put into this model. The other thing though is we send them to the therapist because that's just one way. Just because this therapy didn't work for one patient doesn't mean the next therapy is not going to work. It's like saying, I'm going to go from Anaheim to Santa Clarita, and how many different ways can I get there? Well, there's a couple of different ways. Maybe one way is easier for me, maybe one way is easier for you. So it just means what speaks to you. Then, and I think we can speak to this in a later part of the discussion, is then we can go to medications if it just becomes too much.
Let's address it another time.
Yeah.
So what so far, Dr. Nino said that when the patient is evaluated and when we see that there is no secondary cause, then we look at the primary. So we look to see what kind of anxiety is it. Is it panic disorder? Is it generalized anxiety? Is it social anxiety? So we go with the criteria and we come up with that plan. So as we said that many times, if before going to more biological, we want to make sure that psychological and social problems of the patient have been addressed. So many times patients have been referred to psychologists to talk more. And this is here that I want to ask Dr. Juliet. So now a patient has anxiety, has cleared up that there is no secondary causes, there is primary anxiety, and that person is being referred to you. And how will you evaluate that person? And how, especially in our community, how will you look at the cultural aspects and beliefs of our community when you evaluate and come up with a plan?
That's a great question. Thank you, Dr. Gelyana. I think the concept of therapy is very new to a lot of us, and be able to come to someone that you don't really know and be able to share your, deepest secret or your symptoms. So I think the first thing I'd like to do is build trust and safety. One of the things I emphasize to people is that, especially in our community, like we feel, it's already awkward to come to get help, if you do come to get help, and then have to talk to someone that you might run into it in the community, because our community is very small. So confidentiality is very, very important, and it's something I really emphasize. So I even use example the idea that whatever you're sharing with me in this office stays in this office. Anything you want to share, it's up to you, but nothing gets shared outside. And it's important that they develop that trust with me so they'll be able to speak to whatever it is that they're experiencing. Because a lot of times people, if they're not trusting you and they don't feel safe in this environment, they're not going to tell you a lot of things. They might just tell you about their symptoms, but we all know that, as you can hear, a lot of the, Dr. Gelyana and Dr. Ninos are saying, there are a lot of underlying issues that these individuals probably have never spoken about, and now that they're taking this step to be able. So my first thing is to really make them feel safe and build trust and let them understand that this is a safe environment that they can speak about. The second thing is listen to their story. Now, listening to their story is very, very important. Now, they could speak in English, they can speak in Assyrian, and for me, I speak Arabic, English, Assyrian, and Spanish, so they can speak whatever language they want. The most important is, why is the language important? Is because you want to be able to speak to someone that you can articulate. I don't know about you guys, no matter how good my English is, there's a lot of words that I feel like I can articulate a lot better in whatever language if it's Assyrian, if it's Arabic, whatever language I've learned my feelings with is very important. So I want them to be able to allow them to speak in their own language, and also allow them to be able to express to me what is it that the context of their, so if they're saying to me, for example, I can't sleep because I'm thinking a lot. And we Assyrian, we think about the bills and the family and I don't know what. And so I want to know what that really means for them. I want them to be able to say, I'm not sleeping very well. What does that mean? Are you not sleeping because you don't have good sleeping habit, like Dr. Ninos was saying, or is it that you're really thinking about a lot of stuff that are not in your control? So that's really, really important. It's listening to their story. Remember, when they come to me, I'm the first person, or maybe the second, that has really, really given them the space to talk about their symptoms, to talk about their story, to talk about how they feel. So I want to be able to not be able to have that, that attention to them, to know that their story is very important to me. The other thing is, cultural meanings of anxiety. I know as a society and as a Syrian, and growing up as a Syrian, it's like whenever, I don't know, when I went into psychology, my mom was like, why can't you be a real doctor? Like, you might go crazy by being able to, learn psychology. And so I think we have a lot of stigma about psychology and what does that mean. So we see it as weakness. So if someone comes and says, I'm really having these symptoms, my chest is like tightened, I feel like I'm having a heart attack, but I go to the doctor and the doctor says there's nothing wrong with you. I think we do see it as a weakness. So we come and they tell the family, and the family's like, oh, there's nothing wrong with you, just pray about it, or just ignore it. And I think these are things that are very, very important for me to know culturally, what does that mean in your home. Now, I could be Assyrian, but it doesn't mean that I know everybody else's. Also, our home and the way we're raised and the way we think about mental health is important. How I interpreted mental health in my home, it doesn't mean that that is the same thing. So the cultural context doesn't just come because you're Assyrian, but also what does that mean in your family? Like if you recognize, if you were diagnosed with anxiety and if you had to be on medication, what would that look like? And then I think the last few things is identifying support system. We as a collectivist society, we go in 2s and 3s and 4s, as you know. And so it's important to know, what is their support system? Do they have a support? If they did recognize that they have anxiety and they need medication and they need help therapeutically, are you going to have support? Is there someone going to be supportive? And also identifying what their support system. I'm like Dr. Ninos, I'm not trying to push religion, but I think because a lot of times, in my experience, there's been people that have some sort of a religious spirituality, if you want to call it, some sort of a background. They tend to rely on that whenever they're having difficulties. Not that they should just go to church and pray and think that that's going to go away, but also to know what is their support. Is it praying? Is it their family? Do they have friends? Some of us immigrated and didn't have any family or friends. What is their support system? And then the last thing I do before they leave is I try to give them some sort of a technique that they got to leave with, but I don't overwhelm them with the treatment plan. Treatment plan is something, I don't know if you know, when you go to, you can go to psychiatrists or psychologists, we have to develop a goal, so that would be like, your Google map in a way for therapy of what are you going to be working with. So we're not like talking forever, but at the same time, they're already feeling vulnerable. They just spoke to me and said a lot of things they probably didn't think they were going to. And then now I want to just give them a small step. I can teach them breathing, for example. I can talk to them about maybe the overthinking that you have, we can channel it to just doing it half an hour a day. Pick your time, for example. Maybe we can have them slow down. I want to make sure that they realize that the anxiety is not in control of them, but they are in control of their anxiety. And that goes back to that, what is in my control, what's not. Your symptoms might feel that they're not in your control, but once you learn how to breathe, to slow down, to channel your thinking about, maybe I should just think about these things, my problems and my bills and all the other stuff, maybe I should just think about them 12 to 1. Whatever. It's whatever works with that patient, that's what I do. And then we channel it, I teach them breathing, and then they leave. And then we decide before they go that, look, you need to have at least once a week, you need to come. I usually say 5 sessions just to see it's a good relationship. It's a relationship after all. They might not like me, I might not like them. And that's really important. They have to like their therapist in order for them to feel safe with you, right? So I just say, let's try 5 sessions. And I usually do cognitive behavioral therapy, which is CBT for people. So which means that I give them tasks, I give them homework to do before they leave. So we'll try it 5 sessions. If it works, fine. If it doesn't work, we're either gonna look for something else. But before they leave, I give them something simple, easy to do, and then I check in with them the next time they come. Thank you.
Thank you very much. So as you see that Dr. Ninos, Dr. Juliet, they both mentioned about spirituality. And there are now, we said that everything is biopsychosocial, we know. And nowadays, there are many textbooks that they add the 4th, let's call it dimension of spirituality. So they say that every illness we should look at the biopsychosocial spiritual way of it. So that's something evidence-based medicine supports that. And whatever we learned from Dr. Juliet is that going and talking to a therapist is confidential. And something that also I want to add from an American psychiatrist, Dr. Kohut, years ago, he said, the need that all of us have to be heard by someone and understood by someone is like a need for oxygen. So when we don't have somebody to listen to us, in family, once you start talking, the other person will tell you, okay, what to do, what not to do. It's not there to listen and understand you. So that's a need for oxygen. And many times we want to go to someone who's not judgmental, and whatever we say will stay there. So remember, all the physicians, all the psychologists, all the social workers, all over the country, it's confidential. Whatever you say there, you leave the room, stays there. The exceptions, the law, those things, those are different. But whatever you say, you can go and talk, and it's very confidential. So thank you very much. So we said that Christina works with Assyrian, Chaldean, Syriac Mental Health Organization. And we know, Christine, that your organization does a lot of surveys. And recently you had the results of one of your surveys. Can we have the results regarding anxiety to know more about our population and the anxiety among them and what they think? Thank you.
Absolutely. Thank you, Dr. Gelyana. Based on our ACS Mental Health Needs Survey done in 2024 and supporting presentations, here are the key statistics specifically related to anxiety in the Assyrian, Chaldean, and Syriac community. Out of 121 people, 72% of survey participants wrote in anxiety. It is one of the top reported conditions affecting our community, alongside depression and PTSD. Survey participants identified anxiety as a major pressing mental health issue that people are struggling with, particularly among youth and young adults. 87% of respondents believe there is a stigma around mental health in our community, and 85% have either personally experienced or witnessed stigma when seeking help. This stigma directly discourages open conversations about conditions like anxiety. 72% reported they have never received any mental health education specific to our community, which limits awareness about recognizing and managing anxiety. 77% are unaware of mental health services specifically tailored to Assyrian, Chaldean, and Syriac needs, meaning many with anxiety don't know where to go for culturally competent care. Community-identified contributors to stigma around anxiety and mental health include concerns about marriage prospects and family reputation, cultural and religious norms that pressure individuals to remain strong, shame, gossip, and fear of being seen as lazy, weak, or crazy, intergenerational trauma, and high expectations within families. Anxiety is one of the most pressing and recognized mental health challenges in our community. But stigma, lack of education, and limited awareness of resources prevent many from seeking help.
Thank you very much. So maybe for some of us, the results were a little shocking, but these are like about more than 100 people responded to their survey. And you see that 80%, more than 80% in some of our days, they are dealing with anxiety. So again, this is just a need in our community, so we should know it. And again, I want to go to the basics. Anxiety is unpleasant feeling and uneasiness, something, and when we say that it causes us problem is that when firing is too much in the brain that interferes with our daily functioning. So people even cannot eat or sleep or do their daily activities. Here again, I talked at the very beginning that there are two great social workers in Chicago, Assyrian social workers, Linda Nissen and Rania Jendu, that they were with us during all this panel. We had it during the Zoom in the last few months to prepare for this. And this is the summary that they told us to let's share with you about anxiety symptoms at different ages. So for example, ages at 3 to 12 in children, usually anxiety is with whatever we call it somatic symptoms. They will cause, like I have like stomach pain, headache, those kind of things that they come, or they don't want to go to school, they refuse to school, they don't want to do homework, they withdraw from their friends. So when we see those things, then we can just say, okay, that this kid is dealing with some kind of anxiety. At teenagers, usually it's with irritability, mood swings, more than whatever we expect from teenagers. Or on the other side, they go to the extreme perfectionism when they have the anxiety, underlying anxiety. Again, teenagers with anxiety, usually they are withdrawn from their friends. And they go to the risky behavior, and this is the age that we really worry when they go to self-medication, substance abuse, and alcohol. At ages 18 to 30, again, out of proportion, they worry about performance anxiety, obsessive thoughts about their daily activities, their school, their job, and burnout-like symptoms all the time. They are tired, and maybe this is just anxiety. Ages 30 to 60, again, it's out of proportion, worrying about finances, parenting, etc. And ages 60 above, usually again, is when they worry about their family, their future, and end-of-life issues. Okay, so we learned about anxiety, secondary causes, primary causes, therapy. So a person, Dr. Ninos, goes, you send to therapy, you talk yourself, you send to therapist, but comes and says that more than 50% of symptoms haven't been resolved. What do you do? Will you think about medication?
Yeah, so when thinking about medications, we have different ones we can go with, but before I even go there, the first thing I will tell the patient is that you can't just take medication. I still encourage therapy. And I make an analogy, in no way do I condone steroid use for working out, but I make the analogy that the guy that wants to get big muscles with steroids takes the steroids and goes to the gym and gets big muscles. But you cannot just take steroids and get big muscles. You still have to go to the gym. So to get rid of this anxiety, you cannot just take a pill and avoid your problem, avoid what's going on. You need to do the therapy together for it to work. So that's how I push it, that's how I see it. So then when we go to medications, what are we doing? We're starting usually a serotonin agent, and that's out of the scope of this discussion, but they're neurotransmitters. So imagine your brain cells are two brain cells here. You got neurotransmitters coming from one brain cell going to the other, and it's a back and forth, and it shoots to the next one. Sometimes the volume of this neurotransmitter is low, and what we do with these medications, it makes that volume goes up, and it prevents it from being reuptake, and after a while it gets better. But that takes time. It takes anywhere from 2 to 6 weeks to kick in. So if you guys have heard of like Zoloft, Prozac, Paxil, these kind of medications, they take time to kick in. So what do we do in the immediate moment? Another analogy, if you're not getting tired of my analogies, it's like grass. Do you want to kill the grass or do you want to just mow the grass? So we want to kill the grass, but it takes time. So in the meantime, we'll mow it. What are we mowing it with? With medications like benzodiazepines, which are controlled substances, but like Xanax, Ativan, Klonopin, you guys have heard of these, or hydroxyzine, Benadryl. There's other medications we can use like Buspar and so on and so forth. The list goes on and on. But the bottom line is we have an algorithm that we follow. And just because the first one didn't work doesn't mean that the second one won't work. Just like in treating blood pressure. Sometimes you start with one medication, your blood pressure doesn't come down. You need to take a second or a third agent. So those are usually the algorithms we use. That's the steps that I take to treating the anxiety.
Thank you very much. So again, here we want to say there is some maybe obstacle or something that people, they are afraid of going to psychiatrists or to mental health because they put us on medication. Medication has side effect. Yes, medication has side effect. So the Tylenol or whatever medication that you take, even all the supplements that you can use, they have side effects. Why? Because you take it for this purpose, you want to work on that specific part of the brain. But body is not like that. All the body is connected. You give it, it goes through the liver, goes through the stomach, so people will have some side effects. So whatever we say is that no capable person in medical term or in legal term competent person can be forced to take medication if they don't want. Also for minors, it is up to their guardians to make the decision that if they want to give medication to their minors or not. So nobody can be forced, no competent in legal term or capable with medical term can be forced to take medication if they don't want. These are recommendations. And we always say, just like any single decision in life, we look at the risks and benefits, then we make our decision. We want to drive from here to go like to our house. So there are so many problems, but we say, okay, are there risks or benefits? Should we do it or not to do it? Every single day we have so many decisions that we decide. Medication is like that. You will hear the recommendations, you will go home, and then you will decide to take it or not. And if one doesn't work, doesn't mean that the second or third will not work. Unfortunately, many times it goes by experience of the therapist or psychiatrist, but other times is trial and error. Okay, getting back to therapy, Dr. Juliet, something that we have seen in our community, especially in our youth, the separation anxiety, let's call it social anxiety that they have. People are afraid to get beyond their comfort zone. So many times they are short in meeting their potentials. How can you help them, or how we all can help them that they go beyond that, beyond their comfort zone, meet challenges and meet their potentials in life?
Thank you, Dr. Gelyana. I also would like to kind of define what separation means, separation anxiety. I think a lot of times, like I was thinking about it earlier today, like if you think about separation, I always feel that it only happens to kids. You know, when we drop our kids to kindergarten and they're crying and they don't want to be left. And so in my mind, I feel like a lot of times when we talk about separation anxiety, we assume that it just happens to our kids when they're leaving us or when we're leaving them. But also separation anxiety can come in a lot of terms, right? I mean, imagine that you've been with someone for a long time and suddenly they're no longer there. They could be because they died, for example, or because they moved away, or they got a job outside of the state. And so you were used to this person and suddenly this person is no longer in your life, right? Or no longer there. You know, you call them, you talk to them, but they're not there to be able to help you with some. And if the person died, And that could be a grief, of course, because you're separated from them, but also that you depended on this person and you depended emotionally and physically, and so they no longer are there. So when someone comes into me and talks about, that they're socially anxious, that they don't want to go out anymore, and when I probe and I understand it's because they have this person in their life that is gone now, or that they feel that there's a separation anxiety from this person that does not, and is either not in their life or not full-time like they used to be. I mean, imagine like when we're used to someone and they travel, or our kids, for example. Although a lot of times we don't think they help a lot, but they really do in a lot of ways. And I think when they go away, we do have that separation. So one of the things I do is I tend to be a psychologist that normalizes things. Not that I'm saying that things are not normal. I think that when I teach to my student, I say that everything is normal until one line when things become abnormal, when they affect us. So it is normal to feel anxious when you no longer have this person, or suddenly you have to be independent and you weren't, or suddenly you separated from, because you moved away. I mean, a lot of us have moved away. We've moved countries, we've moved spaces and places. So the idea is that it's very normal. So I don't want people to come to me and I'm suddenly labeling them and saying, oh, you've got anxiety disorder. I want them to understand that with the way they feel, it's normal. Now, what's not normal is the fact that they can no longer live after this person, or that they no longer can function independently after this person. That is what's not normal. But it's normal to be able to think, I wasn't used to doing these things, now I'm doing it, or this person that used to be in my life no longer is there, or no longer full-time. So I want to be able to normalize it and have them be able to understand what they feel and how they feel. The other thing is, then once I normalize it and I say, okay, I understand that these things, but how is this handicapping you? What is it that you can't do? Well, I can't go to the grocery anymore. I used to go with this person, or I can't walk down the street with this person. I feel like I have a lot of opportunities, but I can't take these opportunities because I'm scared or I'm anxious. Then I try to teach them how to do these. Again, CBT teaches you to do things gradual. So this gradual exposure to being independent. I don't say, oh no, you just gotta do it. There's no other way. Because then that overwhelms the person, and that's not the way we can support them. But we can teach them to do certain things, small steps about something, and then kind of celebrate that, right? If you've never been to a downtown on your own, or grocery store on your own, and this person always takes you, and this person used to do this for me, we can have them do something smaller, in a smaller scale. Go to groceries and stay there for 15 minutes. Try to be able to do something independent that you can celebrate. I never walked by myself. Okay, what can we do for you to walk by yourself? And while they're walking, I also teach them the third thing, which is build a comfort kit. What that means is that I want them to be able to pursue this independent activity or this independent thing, but also have something to comfort them. Remember when your kids used to have that blanket, or that thing that they like to have with them, and when we drop them at their first school and they got to take their bear or whatever, it's important that they have that. So even if we're adults and we don't want to take our blanket, what we do want to take is something that will comfort me while I am pursuing an independent activity. For example, a song that you like to listen to, or a prayer that you like to recite, or a picture of this person. And let's say this person traveled away and they're no longer in your life, and now you have to be independent, right? Having them on a FaceTime while you're doing this, pursuing this activity, it's not a bad thing. You could do that for a little bit until you get encouraged. So it is a risk anywhere when we're trying to introduce someone to do something that they've never done before, and that they did it, but they did it with other people. And because we're a collectivist society, I think it's hard to do independent stuff. And so when people are saying, well, I would like to be independent, I want to move on with my life. I know this person no longer is my life. This person died 5 years ago, and I've never been able to live without them. It's my job as their therapist to be able to help them pursue that. The other thing is strengthening their coping beliefs, right? A lot of times these individuals, my patients will say, what if something goes wrong? What about if I'm driving on my own? I've never driven by myself. And what about something happens? And then I remind them, and what else would you do? What will happen? A lot of times we get caught up with this what if, what about if this goes wrong? What about this goes wrong? So I try to be able to help them understand that what if, yeah, let's say it does. Let's say you're going somewhere independently and you've never been and something went wrong. What will happen? So having them challenge that. I also remind them that we're very resilient. Actually, as human beings, we have a lot of strength, more than we think we have. And I want them to be able to understand that. I mean, we're immigrants, a lot of us. I mean, we came here. We traveled so many places to come here. We challenged ourselves in many ways. We've learned English, right? We learned this culture. Somehow we got to be able to tap into that. And I try to have people understand that you're not really as weak as you think you are. You just think that you are, but you're not. So try to tap into that strength, and that resilience is important. And then engaging their support system. As I said, to me, because I work with a lot of individuals that come from a collectivist society, it's very important for me to see what does their support look like. I mean, are they alone? They're going through all of this, and this person died, and they can't live without this person. They can never be normal again. Do they have the support that they need? What does their support look like? And also, if they say, yes, my family is supportive to me, I do meet with them. I'd like to meet with family members. I'd like to see what can we do to help this person. We don't want to enable this person. We want to help them. And sometimes we're scared also as supportive. So I try to get them all to be on the same page with me, because I don't want to teach them to do something and then they go home and the person says, no, don't do that. Don't listen to her. You know, I want to be able to have all of us to be on the same page. So, thank you.
Thank you very much. So again, here I want to reemphasize that the purpose, the reason of having all these meetings, all these talks last year and this year, and I don't know if it will be again in other years, that Assyrian American Federation wants is that to help to destigmatize. Having depression, having anxiety, having other kinds of mental illness is not a weakness, is not a shame. Lil Khaloma. It is not even a problem with faith, although we say that it's good, spirituality will help, but sometimes we say it's overwhelming. Do you know, in my office, when we have contract with some convents that I see nuns and some priests, and I treat them, and at the same time I ask them to pray for me and my family, because to me just having that anxiety doesn't mean that they are not holy. So this is whatever I just say, that again, going back to having this anxiety, having depression is not break the stigma, is not a shame. So with all of this, we say that if we see it in ourselves, in our family, in our friends, wherever we have this help available. And one of the best sources that we have here is that, again, this Assyrian, Chaldean, Syriac mental health organization that puts everything together and makes it very easy for our community. So Christine, again, I want to get back to you and ask you if you can share the resources that people can have.
Absolutely. Specific mental health resources for the Assyrian, Chaldean, Syriac community. Overall, our website, acsmentalhealth.org/FAQ, has the following resources and links. In the state of Michigan, there's Hope in Counseling, St. Peter's Angels, ECRC Center, Chaldean Community Foundation, Mustard Seed Family Counseling, St. Rita Helping Hands. In Illinois, there's the Inspire Counseling Center. In California, there's the Assyrian Drug Awareness Group, the Assyrian Wellness Collaborative, the American, Arab, Middle Eastern, and North African Psychological Association, and Cove Counseling Group. In Arizona, there's the SAFO Center. In Europe, we have resources in the Netherlands and 2 resources in Belgium. In Australia, we have the Assyrian Australian Association and Mariana Elias Counseling Services. In Lebanon, we have the Assyrian Support Committee in Lebanon. And in Iraq, we have in Baghdad the Assyrian Aid Society Iraq Psychological Center. And in Al-Qush, we have the New Hope Center. In general Iraq, there's the IOM Office, International Office for Migration. Mental health resources unspecific to the Assyrian, Chaldean, Syriac community. In Illinois, there's Thresholds, Trilogy, LSSI, Lutheran Social Services of Illinois, and Kenneth Young's service. In California, there's County Mental Health Plan, national services specific to mental health. In the United States, there's NAMI, National Alliance on Mental Health, SAMHSA, Substance Abuse and Mental Health Services Administration, National Institute of Mental Health, To Write Love on Her Arms, the Trevor Project, Mental Health America, 988 Suicide and Crisis Hotline, and in Australia, there is Lifeline, Beyond Blue, Kids Helpline, Suicide Callback Service, and Open Arms. Based on our survey, the community has reported wanting counseling, education, culturally aware professionals, faith-based integration, and financial accessibility as resources to treat anxiety and related conditions. To address some of these needs, we are currently working on an online catalog of Assyrian, Chaldean, and Syriac mental health professionals and their specialties, location, and contact information to better serve our community and create more pathways to healing. So far, we have up to 55 professionals, thanks to the professionals on this panel, and with the help of our amazing team. If you or anyone you know would be qualified to add to this list, please meet us up after.
So again, if you want more resources, you can contact Christine. And the website that is easy to remember, as we said, Assyrian Chaldean Syriac, Assyrian Chaldean Syriac, so ACS. So remember, acsmentalhealth.org. And if you want specific, then /FAQ, or just go for that, you can get a lot of information. And if they have more surveys, I think it's good that you or others, that if you participate, so we can have more information about it. So we want to open the forum for questions. Thank you very much.
I don't think I need the mic. Okay. Hi, thank you very much. The last one you mentioned, the last paragraph you read, if you could repeat that for the mental health.
To address some of the needs for our community, we're currently working on an online catalog of mental health professionals and their specialties, location, and contact information to better serve our community and create more pathways to healing. So far, we have up to 55 professionals, thanks to the professionals on our panel, and with the help of our amazing team members in this front row here. So if you or anyone you know would be qualified to add to this list, please meet up with us after.
And my question is, once we get that up and running, do you have a list you can email people who want to know more information?
Yeah, there's going to be links to all of the professionals, so if you want ways to contact them, they're going to be listed there.
No, but I mean, once you get it up and running, if I get an email, let us know up and running.
Absolutely.
Okay. Do you have a list coming?
A list for the...
Emails.
People who want to, once you get the website up and running.
Like a sign-up.
No, we can make one. We can make one.
Great, thank you.
Yeah, absolutely. Meet up with us after. Sure.
Thank you.
Yeah.
Hi. Have you looked at the concept of deficiencies, like the link between vitamin D and anxiety and depression? There are vitamin mineral panel tests or neurotransmitters, and linked to digestion. The byproduct of carbohydrates is a serotonin, and byproduct of protein is dopamine. I took some courses in enzyme therapy. So have you looked, do you prescribe that to your patients where deficiencies is a factor? I believe we're all deficient. Have you looked at that, the link between, vitamin D, magnesium? Do you prescribe that, or that's not part of your protocol?
Do you guys prescribe?
Thank you.
So
The question is that, do you prescribe supplements to your patients?
Right.
So part of my routine labs, and when I do an evaluation, I also order a full set of labs. Your red and white blood cells, your cholesterol, your sugar, your liver, your kidney, your electrolytes, and that includes your vitamin D, vitamin B12, and folate levels. Vitamin D, us as an Assyrian population, tend to have a low vitamin D. I don't know why. We need to get out in the sun a little bit more. But either way, that is one thing that some psychiatrists do start the prescription, or a lot of times They'll give you a copy of your labs if they check them and give it to your primary, who can do what they're going to do with it. A lot of times what they'll do is give you like a 12-week prescription and then check it again.
I don't really think it's just Assyrian. I, lived in Kuwait all my life, right? And they're sunny, and it's still vitamin D is very, there's vitamin D deficiency. So over there, they have, most of the time, we get like vitamin D infusion once a month, pretty much. So I don't know if it's just Assyrian or I don't know what happens, but it seems like we're not eating enough vitamin D, and if you're in the sun, you're not. But I mean, it's a good question. There is some relation. There are some research that says there's a relation between vitamin D deficiency and your anxiety and depression. It's not 100%, obviously, but I think if that is, and I think this is the reason why I think it's great that the psychiatrist orders all these the lab result. Now, a lot of times I get people, I'm like, well, did you see a psychiatrist? Did you do your lab? And a lot of times like, no, I don't want to do that. I just want to have therapy. But even, for us, it's very important that we collaborate with a psychiatrist. I know in Kuwait, I have a practice there, and our practice, psychologists cannot be without a psychiatrist for those reasons. So we cannot have our own clinic without a psychiatrist because we have to work with them and have to be able to deal with their medication. And even if they're coming to see me and they're not taking medication, they need to be overseen by a psychiatrist. So I think it's something that you should check all the time. So.
Yeah, and in short, I can just say that vitamin D, we know that works for immunity. So in general, theoretically can say that will help with everything. But evidence-based medicine, in psychiatry, we use vitamin D for seasonal affective disorder.
That's right.
Yeah.
That's specifically, we know that we use for that part.
Thank you for that wonderful presentation. Ramina Jaja from Safo Center, Arizona chapter. Thank you for putting the name out there so that people can reach out to us. As the president of the chapter, a lot of people reach out to me with various symptoms and complaints, and we do some studies on generational trauma, but nothing to the extent that you guys have done. But I was wondering, what is your experience, and do you believe with generational trauma that there is reason to think that we've also developed perhaps personality disorders? Can you speak to that, like narcissistic personality disorders, sociopathic disorders, psychopathic disorders? Have you come across any of that, and how do we handle those? Thank you.
Who wants to answer?
If you let me, I just want to give one comment, then I will ask about others. First of all, I should thank you for mentioning this great question. When I started my practice at the very beginning, I was seeing a lot of Jewish survivals and the children of Jewish survivals of Holocaust. So we were seeing, even later in life, not as a child, later in life, we were seeing symptoms very much like PTSD, symptoms very much like unspecified anxiety, let's call it. We could not classify it in one of those disorders. And they needed treatment. So they never have been exposed to Holocaust, but they have heard it, or the people who have been as a children in Holocaust, somehow it has affected all their lives. So and we see it in their offsprings. I'm sure that if we do this, we will see it in our community. I'm from Iran, so we know that many people in 1918, after Patriarch was murdered, many, they left the villages, they went to the south, to the north, to Iraq, to Russia, they came back. So we, as children of those people, we always have heard those, always have felt their pain. So I think that there is a true thing, and it will be great if we start more, and with help of Safo Center, you guys are more organized and more resources, so maybe we can work on that with volunteers. We can interview and we can come up with some literature. But it's a great question. Thank you very much. Whoever wants could say something.
I think generational trauma is very important to understand, and maybe the next panel should be. I also think that I don't know if there is research that really kind of connects personality disorder to generational trauma, but generational trauma is very serious. The other thing is that DNA does there's a lot of research that says DNA changes with trauma, right? So I think if you think about it, if I have grandparents who are suffering from trauma, which also their behavior kind of like, not only do they transfer anxiety, but they're also teaching anxiety in the way that they're handling things. And then my parents will teach it to me. So partly, I think it has a lot to do with social, and partly has to do with DNA degenerational, right? But trauma is very, very important. And I think when I was saying that I want to hear their story, it's very important to know if they have been some generational trauma. I mean, I work with a lot of immigrants that have trauma, and we talk a lot about, generational trauma, complex trauma, trauma that has happened during their travel here, trauma that has happened there, and a lot of the persecution that happened to Christians and Assyrians. So I think it's really important. I'm just hesitant to say that personality disorder could be related to generational, because we also know that people have had personality disorder that did not have trauma. So I wouldn't say that they're related, but I do say that there is something that it's important that we need to address in complex and generational trauma.
I mean, separate from generational trauma, but direct primary trauma can lead to different types of personality disorders. In my practice, I treat a lot of borderline personality disorder, and a lot of that doesn't just happen, that specific personality disorder doesn't just happen. It's a lot of times as a result of or scar tissue from trauma.
Which could be behavioral too, right? So, I mean, when someone has generational, or someone has trauma, forget about generational. If a mom has trauma, and the way she treats her children can also have a lot of abandonment, right? So it's like depressed mom having children that are depressed. It's also the behavioral, that she's depressed. If she's sleeping most of the time, she's not that active in their life, she's rejecting, she's abandoning, that also can create scar that could be seen as borderline. But I'm not sure if borderline is contributed to trauma as much as trauma is contributing to. Does that make a difference? Yeah. So it's very important. Also the behavior and the way we treat our children growing up, how is that impacting them? So.
Thank you so much. Carmen Morad with the Assyrian Wellness Collaborative. Thank you for mentioning that as a part of your resource and your research. I want to begin by thanking the panel. Thank you for your expertise, and the Federation for paying attention to this very important topic. 10 years ago, the Assyrian Wellness Collaborative became into being. I was contacted by Stanislaus County Behavioral Health because we have a very robust Assyrian community in Stanislaus County. For those who don't know, that's in Central California. About 50,000 Assyrians actually live in Stanislaus County. But our strategy has been, and our main mission statement is, stigma reduction and timely access to care.
Thank you.
But our strategy has been working with school districts, working with social services, working with the seniors. But what we have found has been very effective is, thanks to Dr. Ninos Adams, who was one of our panelists as a professional, where we need cultural competency and sensitivity. When you talk to someone who looks like you and who knows about your value and culture, people tend to feel more valued and understood. So behavioral health has to do with prevention, teaching education about what the early signs are. Intergenerational trauma is very important. One of the people we were able to connect to resources was actually a prisoner of ISIS from Khabur who lives in Modesto. Confidentiality is huge. However, by raising awareness, we can help people to connect to resources. So thank you for what you're doing, and thank you, Dr. Denavi, for raising awareness and scheduling this very important educational conference. Thank you.
Thank you.
Thank you.
Hello, sorry, I'm a bit nervous. I had a quick question. How do you determine when someone should go to therapy? Like, what determining factors or indicators do you suggest for anyone to go seek, whether it's from heartbreak or loss? And is there a time frame? Because I've been to therapy myself. So how do you guys determine what areas to go to therapy for?
I mean, I can answer that as a psychologist. I don't, I think this is what I was just also saying earlier, and what I say to my students is like, everything is normal until it becomes abnormal, right? So when do we decide that we go to therapy is when I feel that whatever it is that I'm going through is not allowing me to function the way I used to function, right? When things start to change in my life and I'm starting to get stressed and I can't sleep and, I know that my behavior is not the same, or people are saying to me, you know what, Juliet, I think you need to talk to someone. I also recommend that everyone should have a therapist, seriously. I mean, there's nothing really. I used to be always impressed with Americans where they say, well, I'm going to my shrink, and I was like, wow, And then I was like, I'd like to be that. I'd like to drink my coffee and say, I'm looking at my shrink, I have an appointment with my shrink. And I feel like we should, it's normal. We all have secrets that we don't want to talk to anyone about, and we all don't want to bombard our friends and our family. And I don't want to be seeing my friends every time, and I have to say, well, I'm going through this or that. I want to have my own time. I pay this person, right? And in this country, you guys can charge insurance. In Kuwait, you can't, by the way, and still they pay cash. The idea is that I want to have that 50-minute, hour, whatever. I want to be able to have it all about me. I don't care if I have a problem or don't have a problem. I just want to talk. And that way, someone's not judging me. I can say whatever I want. So when should you go? If you can afford it, go now. Everyone should have a shrink. If you can't, and it's really getting to really make your life whatever you used to do that you can't do anymore, and people are starting to say, look, I think you really need someone to talk to, I would take them serious.
I agree, so much so that I married a therapist. So
Yeah.
100% agree with you. I agree.
Nowadays people are like, I'm going to my coach. Okay, well, if they don't want to say therapist and they want to say coach, I don't care. As long as you go into someone. Some life coaches are okay. That's another panel, but I think if they're educated and certified, but in Kuwait it's like coffee. Everyone is a coach there, which then bothers me because they're not all educated. But look, if you think that you're better at going to a coach instead of psychologist, it doesn't matter. But I know that a coach cannot diagnose you and they cannot work on your clinical issues. A psychologist can. So, but whatever, you need to get one, just get one.
And if you want to go by DSM, again, the standard, DSM goes when it affects your social life, okay? So when a person is a student, cannot study anymore, doesn't go to school, leaves classes, a college kid, instead of going to the class, just stays in bed, doesn't do homework, and whenever somebody is working, the performance goes very down. When somebody is married, is not detached from the family, marriage has become a problem, or kids. So whatever we call it, when there is your daily life, your social disorder is affected, then we are dealing with anxiety as a disorder. Otherwise, as we said, a little bit level of anxiety we all need it in order to be successful in life. But when it is overwhelming, when the firing in the brain is out of control, then problem starts.
I am an ICU neurotrauma nurse, and in the recent years we've seen, I guess there's a stigma of first generations being here, and they have a high near suicide or successful suicide rate. The big thing is that I feel like that at any age that the parents don't believe their children when they hear them say, I am having this anxiety, or there's something wrong. What advice would you give? Because the older generation, they've been through so much themselves, they kind of have this stigma like, there's nothing wrong with you, just get over it. There's this idea of that. What advice, if you would give any advice, or if you want to give to parents, to their children, to listen to them, or what advice would you say to them so their children feel like they're being heard, because I feel like that's what I see with a lot of first generations here in the United States and working in the healthcare field, that they don't think that their parents understand them when they do have mental health crisis.
So I will say this, and I may not answer your question directly, somebody else might be able to, but as far as with the kids go and parents, we're lucky. In the United States, I'm pretty sure every school has a school psychologist or a therapist. I have many friends who are therapists at the school level. So if the kid is saying it, yeah, it's possible that they're saying something, they're blowing it out of proportion or whatever, but it does warrant just a deeper look. And so that's the first place I would go. Just have them see the school psychologist or school therapist, because they will either say, we can take care of this here, and it's very discreet, they pull them out of class, or they do it in a way where it's not stigma, the other students aren't able to identify it outright. But also they may even tell you, here's some resources, please go to the county. I want this person to not only be seen by the therapist, but I want them to see a doctor as well, psychiatrist. I don't know if that...
Yeah, that's the way that the kids, they go, and the other way about parents, this is whatever we are doing, stigma. So for a parent, when they hear it, they cannot say my child has anxiety, because this is stigma, this is shame. What? This is something bad happened to my family, what I have done wrong that it has gone like that. So it is whatever we should work on breaking the stigma there. And something else I can just say from my experience, maybe 10 years ago, there was a family that had a child with ADHD. School had told them that he needs medication. Parent didn't want medication to give, so he went through some special program. So when he started driving, by age 17, he had totaled 3 cars. So then parents brought him, I remember the mother very well, and just her son was next there, and just said, probably now he needs medication for ADHD. And the son said, I don't want it. And I said, yeah, he's 17, almost 18, we cannot force it. So even if you want to give, so this is the way. So then until probably he will have more, I haven't heard from them anymore. Hopefully hasn't died by another accident. But these are the things that happen. So I think the best thing is that we should work with the parents to break the stigma. And it's not parents' fault that have a stigma. This is the community, okay?
To break some of the stigma, our organization did a campaign last November during Suicide Awareness Month of 100 Reasons to Live. And it's located on our page if anyone wants any inspiration or just reasons to just keep going.
I mean, it's hard, as parents. You think about it, it's hard because we always want to internalize it like we've done something wrong. And we want to make sure that, so I think, if the school counselor has a good relationship with the parents, then we can try. Sometimes it's like it takes, they're failing school or something tragic before the parents can open up. But I think you're right. I think we need to educate. We need more parents to come to these panels. We have to have our priest educated on mental health. We need to have everyone educated. And nowadays it's easy. You open your social media. Everyone is out there talking about something social that has to do with mental health. But it's hard. Believe me, I've worked with some parents that are like so difficult that you just want to, ring them. But and the idea is that, but I also understand that they don't want to internalize it. Because automatically they become defensive, as if you're saying you're a bad parent. So I try to work with parents first and try to make them understand that I understand what you're saying. I don't want my kid to be diagnosed. I have a son who's ADHD, and when it was first diagnosed, I was like, what? He can't be ADHD. And here I'm a psychologist. I'm like, no, I don't want medication. And then I realized when he was on medication, he was doing much better. And I had to put my pride away. I mean, it's hard, but we're human.
It's true.
Thank you very much.
Sorry, I have the next question over here. I hope I'm not making you go over time. I'm just wondering, what's your thoughts on or how do you incorporate into your practices, personalized treatment plans? Do you believe in the Dr. Daniel Amen brain scans? I have a friend that is very dear to me, and she's kind of opened up my eyes to the naturopathic world of things, and there's such things as like neurotransmitter panel tests that show specifically what that individual might be deficient in, etc. So if you could elaborate on that, that's kind of new information to me.
Sorry, if I understood your question, is that looking at the anxiety with different perspective? That's okay.
I guess she was talking about like a specific panel for like a neurotransmitter panel, and you said a brain scan, correct?
Yeah. Hopefully one day we'll get there. At this very moment, we don't have any of those. There are so many test trials. So if they're going like trial.gov, if people around, if you find something and we can go, and it doesn't mean that the results is 100%, but they are working on it. At this very moment that we are talking here, we don't have a standard test. The only test that we have, some genetic testing for medications that even in practice we cannot say 100% works, but hopefully in the future we'll get more into that to become more helpful,
more accurate.
Accurate, but otherwise we don't have. When we send somebody for, we cannot have there are some PET scans that we do it in research, that before depression, after depression, then you see how people work, or with the substance, with the cannabis, before, after, how you see it affects the brain. Those things are there, but it's not a everyday practice that we send it for every person, if that's the question.
So if I could also add, this brings up maybe something on the side topic. We get a lot of patients coming to my clinic that will say, they'll bring some test that they did and say, this says I need to take this medicine. And just to piggyback on what Dr. Gelyana said, we're not there yet. And so a lot of times I'll tell them, bring me your list, and my medical assistant will review it for me. I'll say, listen, this paper says that you should not take X, Y, and Z, and yet you've taken the medication and you're doing well on this one. Or it says you have to take this medication, this is the one that's going to work good for you, and yet you had an allergic reaction to it. So those tests, there's a lot of people trying to make money out there.